Our speaker is very familiar, Dr. A.J. Unnikrishnan. He doesn't need any introduction to us. He will be talking about the SOUListic insights, unraveling the results of SOUL study. So over to Dr. Unnikrishnan.
Thank you, sir. Nice to meet you after a long time, and it's a pleasure to be here again at this conference. I'm going to look at how to interpret and analyze the results of the SOUL study, and these are my disclosures. And we know that oral semaglutide has already established cardiovascular safety in the Pioneer 6 study. So that is already done. And then the SOUL trial was conducted, and that trial was conducted to prove superiority, and it wanted to prove CV benefit with oral semaglutide. It was a randomized trial, 9,650 participants and 800 from India, and one of the largest representation of India participants in a CVOT, and probably the largest in a GLP-1 study. And remember, the primary objective was to demonstrate that semaglutide lowers 3-point MACE. So this was a superiority study. And just to give you an idea of a superiority study, if in a cricket match you are playing for a draw, and then if you get to the draw, you try to win, that's called a non-inferiority study. But if you decide, I'm going to play to win, then it is a more difficult task and it requires a lot of confidence, and that is why the superiority design is very important. I must disclose that I was also one of the principal investigators in India for the SOUL study, and this is the inclusion criteria. We had people above 50 years of age with type 2 diabetes, 6.5 to 10% was the HbA1c, and 100% of the people had high cardiovascular risk. They had at least one of the following: coronary artery disease, cerebrovascular disease, symptomatic peripheral arterial disease, and CKD. One unique aspect of the study was the use of a peripheral arterial disease outcome as a pre-specified endpoint. Probably the first GLP-1 to actually have that outcome, the peripheral arterial disease outcome. And of course, the exclusion criteria, pretty much standard: MI, stroke, hospitalization within 60 days, planned revascularization, and pre-treatment with GLP-1. These were all excluded from the study. If you see the demographics, now these are fairly representative of the patients you and I see in our clinics. Mean age of about 61, the mean A1C is 8%, mean BMI 31, type 2 diabetes for fairly long periods, 15 years, and of course, as I mentioned, good proportion from Asia, and you can see hypertension and there in almost 90%. And if you look at the CVD status and the CKD, 70% had coronary artery disease, and the rest had cerebrovascular disease and chronic heart failure. This is also one of the GLP-1 trials with the largest percentage of chronic heart failure patients at baseline. So that is another important finding, and peripheral arterial disease in about 15%. And you will see that a normal EGFR was seen only in about 30% of these subjects. Now again, very important again, that you will see that in this study, 80% of people were already on RAS blockade. 88% of the population plus were already on antiplatelets, lipid lowering drugs, and 77% were on antiplatelets. So good proportion of patients were actually taking guideline directed therapy for CVD event reduction. And if you see the diabetes medication, 1/4 of the population, 27% to be precise, were already on background SGLT2 inhibitor therapy. So that's also very important to note that many people were already on that, still it showed a benefit. Now this shows you the primary outcome very briefly. The event reduction is about 14%. You have 14% reduction of MACE. But what I want you to notice is that these lines of placebo and oral semaglutide separate very early. In fact, less than 6 months, and this is unique among all the GLP-1s that the curves started separating. The benefits were seen as early as less than 6 months. Why this happened is open to debate, but it happened. And of course, the p-value of superiority was met, and the number needed to treat was 50. And this was the main primary outcome, which is the 3-point MACE for non-fatal MI, non-fatal stroke, and cardiovascular death. Now, having looked at the MACE outcome, which is significant, now I'd like you to see which among the 3 points gave the maximum benefit and which contributed to that CVOT event reduction. And that was non-fatal MI, and there was a 26% reduction. Now, if you see, this is the line of unity, and if all the dots are falling to the left, that suggests protection from semaglutide. So all the dots fell to the left, but particularly the majority, the major benefit to that 3-point MACE was from non-fatal MI. And this is one of the largest event reductions seen with GLP-1 agonists on non-fatal MI. So that is important. The only other study was a Harmony study, but that clubbed CV death and also non-fatal MI together. Now, if you see, these are the other studies which looked at 3-point MACE reduction for non-fatal MI, and you will see that compared to all other studies, the SOUL study showed the maximum non-fatal MI event reduction. Now, this is a long, a big sort of slide to look at in terms of numbers, but I want to highlight 2 points. When they looked at which group, which subgroup benefited, they found that, or rather we found that an A1C more than 8% and Asia region, coming from the Asian region, these were 2 factors which showed a larger risk reduction in MACE, almost 27%. So being Asian, having an A1C more than 8%, greater benefit. And of course, SOUL has now reinforces the larger evidence of cardiovascular benefits with GLP-1 receptor agonists. You can see the cardiovascular benefit is there in SOUL. It was also there in other trials as well. So let's look at some of the secondary outcomes. Now, SOUL reduced cardiovascular death by 7%, and that was good. It also reduced, as I mentioned, this was one of the few, remember this endpoint was actually exploratory for several reasons because of the hierarchical testing. But if you see, this was the first GLP-1 study to look at PAD outcome as a pre-specified endpoint, and there's a very clear signal there. The hazard ratio is 0.71, suggesting that there is a 29% reduction in hospitalization for acute or chronic limb ischemia. And there's another study called a STRIDE study which showed a similar benefit, but this was a first. And if you look at renal outcomes, again, oral semaglutide decreased the 5-point major kidney disease events by about 9%. Of course, this was not statistically significant. In fact, it very narrowly missed statistical significance. But if you see the placebo line and the semaglutide line, there is a very clear early separation of the curves that keeps on going and going and going, showing you that there is definitely a signal, and that was also corroborated in the FLOW trial, which actually focused on kidney outcome as a primary endpoint. Now, it's also important to see what happens to the EGFR, and oral semaglutide, as you can see at the end of 4 years, minimized the EGFR decline, reduced it by about 32%, the fall in EGFR. You can see the EGFR being maintained, and in the placebo group you can see the EGFR falling. So oral semaglutide mitigated or reduced the EGFR decline by about 32%. And if you see this was present across all subgroups, whether the EGFR baseline was more than 60 or less than 60. Now, very importantly, many of these patients, to begin with in the study, 26% of patients were already on SGLT2, and it is said that by the end of the study, almost 49% of these people were taking SGLT2s. So was this benefit because of SGLT2 or on top of SGLT2, or does SGLT2 and semaglutide have a synergistic effect? To understand that, a special analysis was done, and in this analysis you can see oral semaglutide with baseline SGLT2, oral semaglutide without baseline SGLT2. And when you look at the comparison, both these groups, oral semaglutide without baseline SGLT2, oral semaglutide with baseline SGLT2, both reduced the risk of MACE, and you will see the p-value for interaction was 0.6561, which meant there was no difference. People who were on SGLT2 and given semaglutide, people who were not on SGLT2 initially, given semaglutide, the benefit was same, it was equal, suggesting that oral semaglutide gave our patients a benefit on top of SGLT2. And this data was playing out also to reduce the risk of non-fatal MI. There was again the p-value for interaction was negative, and you can see that in non-fatal stroke as well. The p-value of interaction was again negative, showing that whether semaglutide was there or not there, whether SGLT2 was there or not there, oral semaglutide worked. So regardless, the benefit of oral semaglutide is regardless of SGLT2 inhibition, and probably you get benefit on top of SGLT2 inhibition in these trials. So if you just look at that SGLT2, because today every CVOT patients or any diabetes CVOT protection patient is eligible for SGLT2 inhibition. So oral semaglutide reduced the risk of MACE independent of baseline SGLT2, suggests a similar benefits in all groups. And if you see the safety profile was similar with or without concomitant SGLT2 inhibition. And overall, this analysis provides clinicians like us with confidence that it is not SGLT2 or GLP-1, it is SGLT2 inhibitor plus oral semaglutide in people at high cardiovascular risk, and both can be prescribed. If you want to look at this safety profile, the safety profile of oral semaglutide largely similar in, when you look at older trials. You will see that very interestingly fewer participants in the semaglutide group reported adverse events compared to the placebo group, and this was mainly because of infections, infestations, cardiac disorders, and permanent discontinuation were more common with semaglutide, and it was mainly due to gastrointestinal side effect. As we all know, people taking GLP-1 have gastrointestinal side effects. I'd like to conclude by saying that the SOUL trial is the first trial of oral GLP-1 agonist, showing you that there is a robust 3-point MACE reduction, and probably almost you can see among the GLP-1s, you will see that the benefit, if you just take the benefit of non-fatal MI, it is the highest benefit across all GLP-1 trials. The risk reduction of MACE of 14% is consistent with all other CVOTs, not just GLP-1, all other CVOTs like the EMPA-REG and so many other studies. So you have genuine, robust CVOT benefit, allowing oral semaglutide to be leading that CVOT space in people with type 2 diabetes. The CV benefits of semaglutide were generally consistent across all subgroups, whether people were on SGLT2, not on SGLT2. But remember, Asians and people with a high A1C of above 8%, they had a special and a larger MACE reduction. If you see, the overall safety profile is similar to that. I want to add one point, is that in the SOUL trial, 80% of the subjects were able to reach 14 mg semaglutide, which is not very commonly seen in practice. We give 3 mg, we often increase to 7 mg, but we don't give the 14 mg because we worry that whether patients can tolerate it or not. Well, for this study, this was a large 9,000 plus study for so many years. They were able to increase the dose up to 14 mg without difficulty in 80% of the people. The other point I want to make is that this 14% reduction is an intention. That means people who started with semaglutide and completed with semaglutide, and people who started without semaglutide and completed without semaglutide, the benefits were even higher. I think the reported benefit was around 18%. So I think this is a very conservative, this 14% is a very conservative estimate of the CVOT benefit that you get with oral semaglutide. Now if you see finally, oral semaglutide, as I mentioned, is the only oral GLP-1 receptor agonist and is the only one which shows a proven CV benefit among the oral GLP-1 agonists. Remember, the other oral GLP-1 agonists are all in trial phase, and this gives us a very compelling option for our type 2 diabetes patients to have protection from cardiovascular outcomes, adverse cardiovascular outcomes or cardiovascular protection. This gives us a very important reason to prescribe oral semaglutide so that we can protect our patients from cardiovascular outcomes and help them to have a proper event-free survival. Friends, pleasure talking to you and thank you so much for listening to me.